And it is my real pleasure to introduce the first speaker of tonight, Professor Legius. Legius is a clinical geneticist and former head of department of the Center for Human Genetics at Leuven University and Leuven University Hospital. And Erik is a world-renowned expert on neurofibromatosis. So please, the floor is yours, Erik.
Thank you very much, Elfriede, for this nice introduction. Good evening to everybody. I want to give a short introduction on the neurofibromatosis type 1 and type 2 and on the diagnostic criteria that have been recently reworked. Can I have the next slide, please? Yes, next one. So we'll first start with neurofibromatosis type 1. Here you see the well-known features of neurofibromatosis type 1. In general, it is a relatively simple and easy disease to recognize. In the left upper corner, there are the typical cafe-au-lait spots that appear around the age of a couple of months, and usually at the age of 1 year they are present. In the upper middle picture, you see the axillary freckling that usually starts to develop around the age of 4 to 5 years, so in relatively young children. In the right upper picture, you see the cutaneous neurofibromas that usually start to appear around puberty and keep on growing during the rest of the life. In the left lower image, you see a plexiform neurofibroma of the upper arm with hypertrichosis and a hyperpigmentation overlying the plexiform neurofibroma. These plexiform neurofibromas are usually present at a very young age, and they have the most growth potential in very young children. And then in the middle, you see the Lisch nodules and the optic pathway glioma, meaning that already two important features of neurofibromatosis have to do with the eye. And in the right lower image, you see bone abnormalities resulting in a pseudarthrosis. So it starts with the congenital bowing, which then develops in the pseudarthrosis. Next slide. I have been part of a steering committee that has done a lot of work in revising the older NIH criteria that were established in 1987 and to revise the diagnostic criteria. They have been published in the Genetics in Medicine last year, and as you can see, several of these items are related to ophthalmology. So an optic pathway glioma is one diagnostic criterion. Also 2 or more Lisch nodules or 2 or more choroidal abnormalities as seen by OCT, near infrared reflectance imaging, and also a osseous lesion such as a sphenoid bone dysplasia is part of the diagnostic criteria. We also introduced a new feature, which is a heterozygous pathogenic NF1 variant. And you need to have 2 of these criteria fulfilled to make a diagnosis of NF1. One criterion is sufficient if a child of a parent who has NF1 is considered. Now, if you have a sphenoid wing dysplasia, which is very frequently associated with an ipsilateral orbital plexiform neurofibroma, then these 2 separate features count only for 1 criterion. Next slide. So here you see the sphenoid bone dysplasia, the orbital dysplasia, and the plexiform neurofibroma of the upper eyelid in this patient with neurofibromatosis type 1. But if you have only this and nothing else, that we do not consider this sufficient for a diagnosis of neurofibromatosis type 1, because the combination of these 2 features is also seen as an isolated abnormality not related to neurofibromatosis type 1. Next slide. So neurofibromatosis type 1 is related to a mutation in the NF1 gene, heterozygous mutation in the NF1 gene, which codes for neurofibromin. And as you can see here in this schematic, neurofibromin is a negative regulator of the RAS proteins. So it's a negative regulator of the RAS-MAP kinase pathway, and it also acts as a tumor suppressor gene, meaning that if you inactivate both copies of the gene in a particular cell, then it might transform into a tumor cell. Next slide. So biallelic NF1 inactivation in individuals with NF1 is seen in the tumors. So they inherit a heterozygous pathogenic variant in the NF1 gene, but in the tumors itself, in the neurofibromas, in the gliomas, and all other tumors that you can see in neurofibromatosis type 1, the normal allele is also mutated. So you have a biallelic NF1 inactivation, and as such, it's a tumor suppressor gene. But also non-tumoral features show this double hit of the NF1 gene. And this has been shown in congenital bowing of the bones with or without pseudarthrosis, as I showed you before, and also in the café-au-lait spots, in the melanocytes derived from the café-au-lait spots. This biallelic NF1 inactivation leads to an increased signaling through the RAS-MAP kinase pathway. And at this moment, at the EMA level, one particular drug, a MEK inhibitor called selumetinib, has been accepted as a drug to treat symptomatic plexiform neurofibromas in children. Next slide, please. On the other hand, aside from the tumoral features, we also know that in children, also in adults with NF1, there might be cognitive problems that are reflected into learning disabilities that can be of different sorts, and also an increased frequency of ADHD and autism spectrum disorder. And it's kind of funny that the mutation in one particular gene results in such a wide spectrum of potential problems, and not every individual with NF1 has the same cognitive profile. Next slide. Within the ERN-GENTURIS, we have been working on a whole set of guidelines and recommendations for follow-up of patients with neurofibromatosis type 1. And the only thing that I show here is the recommendation regarding plexiform neurofibroma, how you diagnose it, how you follow it, and how you can treat it. And as you can see with the arrow, if possible, and if reimbursed by the national healthcare system, a treatment with the MEK inhibitor might be considered in specific situations where there are symptoms that need to be treated. We are now in the process of summarizing all these guidelines and putting them into a manuscript that will be submitted during this year to a journal for publication. Next. Can I have the next slide? And then there is a mimic, something that looks very much like neurofibromatosis type 1 that we first reported in 2007. Next slide. That is Legius syndrome, and individuals with Legius syndrome have the identical café-au-lait spots as seen in neurofibromatosis type 1. They can also show the freckling, the macrocephaly, and a little bit of Noonan-like facial features. There's also a mild association with learning disabilities, ADHD and ASD, but the tumoral phenotype is not seen in these individuals. So no neurofibromas, no lesion nodules, no choroidal abnormalities are seen. So this is important news for parents of a child with multiple café-au-lait spots that is suspected of having NF1. And in several series, between 2 and 4% of children who are in follow-up at a multidisciplinary NF1 clinic, in fact, have a mutation in the SPRED1 gene causing Legius syndrome. Next slide. So this is one of the publications. It's a publication from our group where we showed that these choroidal abnormalities that are frequently seen in neurofibromatosis type 1 are absent in a set of individuals with Legius syndrome. Next slide. Now, neurofibromatosis type 2, in fact, is a misnomer, because individuals with neurofibromatosis type 2 will not develop neurofibromas, but they develop schwannomas. And therefore, in the same steering committee where we revised the diagnostic criteria for neurofibromatosis type 1, we have been discussing on new criteria to diagnose neurofibromatosis type 2, but realizing that neurofibromatosis type 2 is a misnomer. And so we now propose to call it NF2 related schwannomatosis. There are also other forms of schwannomatosis like SMART-B1 and LZTR1 related schwannomatosis. And so we group them under the umbrella of schwannomatosis because they do develop schwannomas and not neurofibromas. Next slide. And here you see an image of the typical bilateral vestibular schwannomas that have an effect on hearing and equilibrium that usually develop around the age of somewhere between 10 and 20 years of age, but they can also develop before the age of 10, but that's quite rare, and also after the age of 20, and that's also quite rare and usually associated with the mosaic form of this condition. But as you can see here in the challenge in the New England Journal of Medicine, this image was by at least 21% of the people who responded to survey quoted as neurofibromatosis type 1, showing the confusion that exists with many medical doctors between NF1 and NF2, and that's one of the reasons why we want to call it NF2 related schwannomatosis. Next slide, please. So this is a proposal of the new diagnostic criteria for the NF2 related schwannomatosis. This is a manuscript that is submitted, that is under revision, and the revised version has been submitted. So we hope that it will be published soon in Genetics in Medicine, at least in the first coming months. And so the diagnosis can be established when you have these bilateral vestibular schwannomas that I showed you in the previous image, or when you have an NF2 pathogenic variant in two anatomically different NF2 related tumors. But if you don't find the mutation in the blood, then it's probably due to mosaicism. And then there are other features that might lead to a diagnosis of NF2 related schwannomatosis, and these are divided under major and minor criteria, and you need two major or one major and two minor. And under the minor criteria here you see that there are also symptoms that are related to the eye, so the juvenile subcapsular or cortical cataract, the retinal hamartoma, and the epiretinal membrane in a person aged less than 40 years. So also here, visual symptoms and problems related to the eye can be present, and these are not present in the other forms of schwannomatosis, in the LZTR1 or SMART-B1 related schwannomatosis. Next slide, please. So this is an image that shows you the ependymomas, and also gliomas are not present. So no neurofibromas, no gliomas, but schwannomas and ependymomas and meningiomas. Next slide. So this is a care pathway that has been developed for neurofibromatosis type 2, and also a complete document with the guidelines for surveillance and follow-up has been developed within the ERN-GENTURIS. Next slide. Then I will give the word to the next speaker.
Thanks a lot, Professor Legius, for this perfect introduction to the topic of today, NF1 and NF2. We will hand over now to the next two speakers, dealing with ophthalmological aspects, retinal imaging, and also OCT of NF1 and NF2. The next speakers are Professors Dominique Brémond-Gignac and Matthieu, both from Hôpital Necker-Enfants Malades in Paris, in France. The floor is yours.
Thank you very much.
Thank you very much. Can you see our screen?
Yes.
And can you hear me? Excellent. So thank you very much for the invitation. So we've decided that I would present, considering the short time of this presentation. So I'm going to focus mostly on NF1 for two reasons. First, it's not that rare. And second, there are crucial therapeutic consequences. And as you can see, I've listed here the various ophthalmologic expression of NF1, and all of them actually can be seen during childhood. Many of them are actually specific childhood complications. So we're going to go structure by structure, and I'm going to cast some more light on unknown signs, novelties, and of course signs with consequences in terms of diagnosis and treatment. So let's start with the orbit. We've already spoken about superior eyelid neurofibroma, which is quite rare in children, which may or may not be associated with ipsilateral optic pathway glioma and or with ipsilateral ophthalmia with and without glaucoma. It's important to follow them because of the risk for transformation, and also because we have now targeted therapies which we can use, and this has already been mentioned so far. Sphenoid dysplasia is also very rare, with as a consequence sometimes considerable displacement of the globe and strabismus, and also the risk for specific complications due to the dysplastic bone and the consequences of the brain herniation into the orbit. Now, there is a clinical picture which is a classical one, and which should be quite well known by the clinicians. You can see this little girl. She was 6 years old when I saw her with this peculiar picture. Quite subtle, but you can see a slight proptosis on the right side, a slight hypertropia, and a very subtle limitation of elevation of this right eye. The visual acuity was normal and symmetrical, and the fundus just showed a slight edema of the disc. It could also have been normal. It could have been a slight atrophy. And this picture, this clinical picture, is very specific of anterior orbital forms of OPG, optic pathways glioma, which invariably lie on the top of the globe and cause this particular orbital clinical picture. And this, of course, should prompt the prescription of an MRI scan. Now let's carry on with the two well-known leash nodules, which diagnosis can be very easy in old children with very pale or very dark irises, which can be very difficult to see in young infants. And you can see here hardly visible spots, which are going to transform into very visible leash nodules. They are not that easy to see when we are mostly interested in them, which is in young children. And they are not a very sensible sign for NF1. As you can see, the prevalence at age 5 is about 50% of cases, and this prevalence increases with age. I'm just going to mention uveal ectropions with a high risk for glaucoma, very difficult to treat, often very severe glaucomas, due to the specific infiltration of the angle, which may be seen in NF1 and should, of course, be looked for. Let's now talk about the retinal expression of the disease. So the first one, which had been first described by Musi Mendoza, are these peculiar vascular retinal abnormalities, which can be classified as proposed by Moramarco in 2019 within 3 stages: simple tortuosity, quite frequent, 35% of cases; corkscrew tortuosity, rarer, around about 5%, and a very abnormal network which are hardly visible in children. So these abnormalities were first reported as being congenital and stable. We've showed that they actually are acquired and can evolve over time. And you can see here the transformation of this vessel, this vein, this small venule in a little girl between age 2 and 7 years old. New criterion, which is absolutely fundamental for us, the hyperreflective areas, first described by Yasunari in a Lancet paper in 2000, they are not clinically visible. They are very easily visible on infrared pictures, and these ones can actually be easier to perform even in very young children. There is no flash from age 2 sometimes. They also increase in number and in surface over age, and you can see they are very sensitive and very specific for NF1. They can be seen before leash nodules, and we're very happy that they are now a diagnostic criterion. So it's actually much easier to perform only infrared imaging, although OCT, of course, can be performed, but it's not necessary for diagnostic, and we don't find it much useful in the daily clinical practice. In OCT, what will you see? You'll see these hyperreflective areas here at the uppermost superficial layer of the choriocapillaris, the Sattler layer, and you can also see them in en face OCT, which is quite nice to be seen, but has no interest in clinical practice, in our opinion. Now, of course, the most severe complication probably over childhood and for sure ophthalmological complication of NF1 in children are the optic pathways glioma. I have already mentioned the orbital form for them, but most of them are actually grade B or C of the Dodge classification, and they do not give sign of orbital affection. I've here showed you the age at diagnosis from a personal series of 86 cases of children with NF1 and OPG, and you can see that the mean age for diagnosis is around 4 years. You can also see that the red ones are the treated ones, so a minority of them will be treated, the other one will just be followed up clinically. Classically, the diagnostic relied on visual loss or early puberty and or radar ICP for the biggest forms of OPGs. And more often, and we can be very happy about it, they are diagnosed on very subtle clinical signs or even infraclinical signs, as decreased OCT, and OCT is now performed on a routine basis in such children precisely to see very early signs of OPGs. They also are sometimes diagnosed on an initial MRI, which I'm going to say a few words about in a few minutes. The visual outcome on the whole is quite good. The earlier the OPG, the more severe the prognosis. But also, whatever the age, the earlier the diagnosis, the better the prognosis, because the earlier the treatments can be administered, and they are first line usually chemotherapy, Avastin for some specific cases, and more targeted therapies as second line treatment if the first line is not efficient. So which follow-up for children with NF1? Well, these are the recent French recommendations, which are very close to the European ones, and which are a bit more tight than what has been recommended in the past. So we recommend a clinical examination every 6 months until age 6 years. From age 6 years to puberty, an annual evaluation. From puberty to age 18 years, a clinical examination every other year, and there are no recommendations after age 18. We want to remind that these patients should get an ophthalmological follow-up. We might suggest at least every 4 years, because we see too many NF1 patients who haven't seen an ophthalmologist over the last 10, 20 years, and they may get complications also over adulthood. Now, when there is a known OPG, then the follow-up is determined by a consensus during neuro-oncology staff meetings, and they are usually seen every 3 to 6 months according to the age and the severity of the OPG. The main reason for this systematic follow-up of children with NF1 is, of course, diagnosing OPG on time. There is a current consensus against repeated MRIs for the diagnostic of OPG, the OPGs with only OPGs with visual repercussion are going to be treated. These repeated MRIs are not useful and can be stressful. We should perform complete clinical plus paraclinical examination, and if abnormal, refer the child to a reference center and or plan an MRI scan. Now, in the next few minutes, I'm just going to say a few words about NF2, which is a misnomer, which is also much rarer, and which does not imply similar treatment consequences as NF1 in children. So it can be diagnosed on oculomotor pulses secondary to sphenomas or meningiomas of one or several cranial nerves. Optic sheath meningiomas are very rare in children, especially in young children. They can be diagnosed on uni or bilateral subcapsular cataracts, sometimes quite dense, as in this example. And this has to be known on childhood epiretinal membranes, which may get this specific or relatively specific flame-shaped, as you can see here, and was shown recently by Weisberg, and or retinal and or combined hamartomas of the retina and the RPE. So I've put these brackets about on combined because these hamartomas actually have been the topic of a lot of confusion over the last years. If we read again the only histological paper on them from 1969, we can see that they are RPE cells in the neurosensory retina. These hamartomas are not developed from the RPE. And the way we can see them today, is that they are perivascular proliferation of RPE cells in the neurosensory retina. They start from the innermost layer and they progress progressively to the more external layers over time. And they should prompt examination so as to rule out the diagnosis of an NF2 if seen in a child. So to conclude, the role of the pediatric ophthalmologist in NF2 and even more in NF1 is crucial for the diagnostic, for the follow-up, and for the indications for treatment, and also over the follow-up of the treatment. I thank you for your attention.
Thank you.
Thanks a lot, Professor Robert, for this excellent talk and for providing insight into the ophthalmological features. Then it is my pleasure to introduce the next speaker, Professor Kathleen Claes, who is a molecular geneticist from the Center for Medical Genetics at Ghent University Hospital in Belgium. And Kathleen will talk about molecular aspects and genetic testing of NF1 and NF2.
Okay, thank you for the introduction. I will talk about molecular aspects of NF1 and NF2 genetic testing. You don't need to look very far in PubMed to find several papers indicating why molecular genetic testing of NF1 is warranted. It's especially in children that may have only limited clinical manifestations of the disease, limited to caveolé spots and freckling. And Erik already pointed out that this may be mixed up with other diagnoses like Legius syndrome caused by germline mutations in PRET1, but also patients with constitutional mismatch repair deficiency caused by biallelic inactivation of mismatch repair genes may have caveolus spots, and patients with Noonan syndrome may also have caveolus spots. So that's why it's important to do molecular genetic testing so that the NF1 diagnosis can be made early as in life, and then appropriate surveillance can be started. And also sometimes parents may have another child with wish, and if the underlying genetic defect is known, they may opt for a prenatal or options or for pre-implantation genetic diagnosis. This is the NF1 gene. It's located on the long arm of chromosome 17, and it's a large gene spanning at the genomic level 300 kb. What you see here is that there are several functional domains present in the gene. There are two major isoforms. One isoform, the smallest one, is the most abundant form in the central nervous system, and the longer isoform has an extra exon here, and this is the predominant transcript in most tissues. We use for genetic testing most often we work with this transcript in diagnostics. The reason why NF1 testing is a bit complicated is because it has several pseudogenes. These are genes that are very homologous to the real NF1 sequence. However, these pseudogenes, they encompass not the full coding sequence of the NF1 gene. They are only partial, and they contain mutations, and therefore they are not expressed. So therefore it's a good idea to analyze the NF1 gene at a cDNA level. And more than 22 years ago, my former supervisor, Ludwine Messiaen, published this landmark paper where she showed that with a combination of gDNA and cDNA-based techniques allowed her to identify the causal mutation in more than 95% of patients with fulfilling clinical criteria. And it's also thanks to her work that we know now a lot about the NF1 mutation spectrum. As NF1 is a tumor suppressor gene, you will not be surprised to see that the mutations in this gene are loss of function genes, and truncating variants resulting in the premature stop coding represent about half or nearly half of the mutations. However, there are also a large proportion of variants that are affecting mRNA splicing. And interestingly, about 1/3 of the splicing alterations would not be found using standard DNA diagnostics. We have in our database several variants like missense variants, but also silent substitutions and nonsense variants that actually lead to aberrant splicing and that were not predicted by bioinformatics algorithms. Furthermore, in 3% of the patients, deep intronic mutations are found that lead to pseudo-exon inclusion. And another interesting category are the variants that are insertions of large retrotransposable elements like allo repeats, long interspersed repeats, and poly-T stretches that lead to skipping of an exon. And these are detected because at the cDNA level you see aberrant messenger RNA splicing. However, at the gDNA level, there is no logical reason to be found why this exon is skipped. And in some cases, this kind of insertions were identified. 17% of the mutations are missense variants, mainly in the gap-related domain and also in the cysteine-serine-rich domain. And then another category are the NF1 microdeletions, representing 3 to 8% of all mutations. And we distinguish several types. The type 1, type 2, and type 3 are the ones that have fixed breakpoints that can be seen here. And they are due to rearrangements that occur due to misalignment of low copy repeats that are here flanking the NF1 gene. The most prevalent one is the largest deletion of 1.4 megabase that includes not only the NF1 gene, but also 14 other genes, including SUS12, and this has as a consequence that these patients are more susceptible to malignant peripheral nerve sheath tumors. These deletions occur during the maternal meiotic process and are associated with a more severe phenotype. Type 2 deletions and atypical deletions with random breakpoints, they occur more often during mitotic divisions after fertilization. And this means that there is often somatic mosaicism and that the phenotypes associated with these deletions are more variable. Do we see other genotype-phenotype correlations in the NF1 gene? Well, only in 10% of the individuals. And the most valuable information is coming from a database of University of Alabama that was built up by Ludwig Messiaen, who screened more than 8,000 individuals with a pathogenic NF1 variant, and she identified more than 3,000 different NF1 variants. However, only 31 of these had a frequency of more than 0.4%, allowing to establish genotype-phenotype correlations. So the type 1 microdeletions, we have already talked about it, they have a more severe phenotype. There is another in the small deletion of methionine at codon 992. This was originally published as a mild variant with no neurofibromas, no optic pathway gliomas, and no spinal neurofibromas. However, in a follow-up publication, there were found in nearly 5% non-optic brain tumors that were mostly low-grade and asymptomatic, so that's why they were probably not observed in the first publication. But nearly 40% of the patients had cognitive impairment and learning disabilities. Some other genotype-phenotype correlations have been established for missense variants. So most missense variants show milder phenotypes, except missense variants affecting the CSRD, so the cysteine serine-rich domain. And here I underlined it because for this public, in about half of the patients with mutations in one of these codons display optic pathway gliomas. Furthermore, they are more, compared to a general NF1 population, they have more plexiform neurofibromas and spinal neurofibromas and skeletal abnormalities, and they have also a high predisposition to develop malignancies. Missense variants in the tubulin binding domain and in the gap-related domain display a Noonan-like phenotype in about 25% of the patients. Variants in the gap-related domain have a higher prevalence of cardiovascular abnormalities, and some show also spinal neurofibromas, while in the variant in the tubulin binding domain rather has a mild phenotype with no neurofibromas or spinal neurofibromas and no symptomatic optic pathway gliomas. So unfortunately, not many links with ophthalmological phenotypes based on the genotype. Eric already pointed out that NF1 is a tumor suppressor gene and that you can find second hits. I want to come back to this because we have several cases where mosaicism is suspected and we cannot identify a mutation in blood. And what we do then is we study the affected cell type. This means the Schwann cells are cultivated from neurofibromas, or the melanocytes are cultivated for café au lait spots. And we always advise them to take at least 3 biopsies so that we can distinguish between the first hit and the second hit, because the first hit is expected to occur in all 3 biopsies. We recently evaluated retrospectively in our cohort of mosaic mutations that were not identified in blood, if we could detect the mutations also in the fibroblast or the keratinocytes of the that were also cultivated from the same café spots as the melanocytes. However, we did deep sequencing but could not detect these. So for some cases, it's really important to study the affected cell type. So, like the other speakers, I will also briefly touch on molecular testing of NF2. NF2 has also 2 major isoforms, and they differ here at the end. So, the longest isoform has the exon 15 and 17, and the shorter has the exon 15 and exon 16. The gene is located on the long arm of chromosome 22. Also here we see mainly loss of function variants. So the truncating variants lead to a severe phenotype with a higher tumor burden, while the variants that lead to mutant protein and like missense variants, in-frame deletions and some splice variants, but also if you have a whole gene deletion, this results in a milder phenotype. Also here, deep intronic variants resulting in aberrant mRNA splicing represent about 1% of the mutation spectrum. And also for NF2, a large rate of mosaicism has been described, especially in older patients. And it's important to keep that in mind. So NF2 can lead to schwannomatosis. But also other genes are associated with neurofibromatosis, like SMARCB1 and LZTR1. They also have, SMARCB1 has 2 isoforms and LZTR1 has 1 major isoform. Tumorigenesis in schwannomatosis is not as classic with the 2 hits, like we know from the Knudson hypothesis, but it involves the inactivation of at least 2 tumor suppressor genes, and that's what I wanted to show here. So the LZTR1 and the SMARCB1 are also located on the long arm of chromosome 22. When there is a germline mutation, either in SMARCB1 or in LZTR1, what do we see in the schwannomas? Somatically, there is a loss of the wild type allele of chromosome 22. So this can be a complete or partial loss of chromosome 22, but especially affecting the region where the 3 genes are located. And then there is another hit is required, namely inactivation of the NF2 gene on this mutated allele, and this can be seen as different NF2 variants are observed in each schwannoma of the same patients. And it's important to establish this diagnosis because the phenotypic presentation of schwannomatosis affected individuals can overlap with mosaic NF2, and by checking the schwannomas you can distinguish if it's mosaic NF2 or if it's due to a pathogenic variant in one of these genes. So, and hereby I would like to end my presentation, and I'm happy to take questions after the session.
Thanks a lot, Professor. This was another great presentation. And then last but not least, it is my pleasure to introduce the last speaker of tonight, Mr. Claas Röhl from the Austrian Center of Expertise for Neurofibromatosis in Vienna in Austria. And Claas, you will speak about patient testimony, added value of early genetic testing. Floor is yours.
Thank you very much. I hope it works and you can see my screen.
Yes.
Okay, great. Thank you so much for this opportunity to speak and to talk a little bit about the patient perspective and what it's like to deal with NF1. I'm the founder and chair of the Austrian NF patient organization, NF Kinder, and also co-founder and chair of the European umbrella organization, NF Patients United. So first I want to start with my journey from a caregiver to a patient advocate, because my daughter, my first child, was born with NF1. But at first, and that's the typical patient journey, everything was unsuspicious at birth. My daughter had just one Kathleen spot on her cheek, but there was no reason for concern, and we were not even confronted with the term neurofibromatosis type 1. But like in most cases, after 3 months, several new Kathleen spots started to appear. We did online research on and found that this might be related to neurofibromatosis type 1. And if you Google neurofibromatosis type 1, you find very shocking images in the Google search with worst case scenarios and severely disfigured patients. Our pediatrician at that time was not familiar with NF1, so we really had a roller coaster ride of emotions, visiting several doctors, some saying it is NF1, others saying it probably is not, so a lot of confusion, sometimes traumatic experiences, because the worst thing we ever heard was that we should enjoy the time that we have left with our daughter. But finally, we were able to find true experts for NF1 at the neuro-oncology department of the medical university. And that was where genetic testing was initiated. And we had the diagnosis confirmed at age 7 months of our daughter. So we had to go through 3 to 4 months of this state of uncertainty, and it was really a huge burden for us as a family. So next we had to learn how to live with NF1, so to do regular assessments and controls, which always means a lot of burden and nerve-wracking moments. We educated ourselves about NF1, but we also had to deal with this constant psychological burden that really affects the whole family. But we tried to stay optimistic, and we're happy that our child was developing well. In the center where we were taken care of, which is now the NF Center of Expertise in Austria, routine MRIs were performed on an annual basis. And at 2 years old, a routine MRI discovered bilateral optic pathway gliomas in our daughter, while the ophthalmological assessment just a few weeks prior was unsuspicious. And this, of course, hit us very hard again. It came with a lot of anxiety and fear, but we hoped for the best, that the follow-ups will show, a stable disease. But unfortunately, the follow-up MRIs that were done every 3 months showed a rapid growth of the optic pathway gliomas. So the decision was made or recommended that we start chemotherapy before the sight of our daughter deteriorates. This meant for us to really reorganize our life, because it was 18 months of chemotherapy. So we tried to prepare ourselves, but also prepare our child for this journey. And the journey of a child at that age undergoing chemotherapy is, of course, lots and lots of hospital visits, sometimes, painful procedures, but our daughter was, just a warrior and super compliant with everything, and gave us a lot of inspiration and also courage we could learn a lot from her optimism. So when she was 4 years old, the chemotherapy was finished. Luckily, we had great outcomes. We had a significant reduction of the tumor size. We had no impairment of her vision, and we did control MRIs every 3 months after that. Thanks to an MRI training that is offered by the psychologist in our center, our daughter was able to perform the MRIs without sedation when she turned 4 years old, and we never had any problems after that. So the situation today is luckily all the tumors are stable. She doesn't have any vision impairment. We went back to less frequent MRIs. We do them annually now. And we luckily also have no onset of any new NF1 related symptoms. But this experience really inspired me to do everything I can to support people with NF1. And that led me to start the Austrian patient organization NF Kinder. In a very nutshell, what do? We help to set up the first Austrian Center of Expertise for NF, which is now also an associated center in the ERN-GENTURIS. We are working constantly on setting up health services in and outside of the clinics. For example, we could establish the first rehabilitation program for pediatric NF patients last year. We provide a lot of information on and offline for patients and caregivers. We organize symposiums and lectures. We try to raise awareness and work with the media on a national and regional level. And we also try to fund research activities and build a growing national and international network. And with NF Patients United in a nutshell, some of our members are actively involved in the ERN-GENTURIS as EPACs, such as myself and an NF2 patient as well. And others are contributing to works such as the guideline development for tumor management in NF1. We are also involved in the RAINS group, who are dealing with working out outcome measures for future clinical trials. We are also organizing meetings and giving lectures. We're an associated partner in the IMI project, EOPERL, and we do joint awareness campaigns on a European level together. I want to also use the remaining part of my time to give another patient testimony that didn't go as smoothly as our journey did, but the start is again quite similar. So we're talking about identical twins that were unsuspicious at birth, but then after a couple of months, several Café spots appeared. And the pediatrician at that time saw no reason to act. And an ultrasound assessment actually of the heart was done for another reason. And there was the first time that suspicion was raised about NF1. But the doctor just told the family that they could Google it and no further steps were taken. So Google, of course, terrified the parents. But the pediatric at that time, again, didn't want to take any measures, also didn't think that a genetic test would be helpful because, quote, there is nothing you can do anyway. So the family was unsatisfied, sought another doctor's advice. Genetic testing was arranged, and the results actually came back when the family was just moving to Germany. So they never had genetic counseling, and also there was no control assessments being planned. There was no case manager for the family, and actually access to information was really difficult. The whole surrounding of the family and also some doctors even recommended that they shouldn't deal with it too much because there's nothing they can do to prevent any symptoms from appearing. So when the family moved back to Austria, the children were about 2.5 years old, and actually a routine ophthalmologic assessment was done that revealed a suspicious optic nerve and also revealed that in one child, the vision was only 60% left. MRI was taken. The diagnosis was made that there's unilateral optic pathway gliomas in both children. They were referred to a local clinic that told the family to watch and wait without even looking at the MRIs. So again, the family was unsatisfied and sought further advice, and they turned to the Neuro-Oncological department in Vienna, which is now the NF Kinder Center of Expertise for NF. So follow-up MRIs were arranged, and the recommendation was to start chemotherapy because of the growth of the optic pathway gliomas and the worsening OCT results. So the chemotherapy was started in Vienna, but continued at the regional clinic. There was a premature stoppage because of an allergic reaction, and control assessments were planned every 3 months. Both children responded well, vision was stable. About 1 year after the chemo was finished, the OCT scores worsened again, and about 1.5 years after the end of the first chemo, the next chemo was started with one child first and 6 months later with the other child, this time with another agent. The side effects were tolerated better, and again, it showed good response in both children. Again, the family started to do the therapy in Vienna, but because of the extremely high travel burden, they continued therapy at the local clinic. To find adequate social support was very difficult for the family at that time. Again, sight was stabilized, vision was stabilized, but 6 months after the chemotherapy, again, the OCT scores worsened. Therapy with another agent, with Avastin, was started. Sight stabilized again, side effects were under control. Again, another 6 months after chemo, the situation worsened again. So in September of last year, both children started with the therapy with the MEK inhibitor. So far, they don't experience side effects and sight is stabilized. But of course, has been a long story for the family so far. I asked the parents what were the main challenges during the therapy. And they said for them it was the travel burden, also the financial burden, to organize so many things, and that the whole family suffered because suddenly the whole life is aligned to the needs of NF1. I asked them what should have went better, and they said that the communication between clinics was sometimes not ideal and should have been better. The parents had to invest a lot of time and energy to make sure that the information is passed on correctly. Pediatricians should be better informed about NF1 and take action sooner. Counseling would have been so important, genetic counseling, and an earlier start of the intervention might have saved the vision of their children, because now they have many limitations in everyday life or in sports. What was helpful? The family said it was extremely helpful to be managed by an NF1 expert whom you can trust. It was extremely helpful to have psychosocial support. And also the family stated if a patient organization like NF Kinder would have existed back then, things would have probably gone differently. And when I asked about the wishes for the future, the family said that information on NF should reach really all health professionals, because as you heard, NF1 is such a diverse disease with so many manifestations. Early diagnosis and genetic counseling for all NF1 patients should be standard. Early referral to NF1 experts who are taking responsibility of the case management is wanted. And doctors should also refer actively to existing patient organizations and work with them closely. So I hope I stayed in time to give you 2 different patient testimonies and talk a little bit about our work. So thank you very much for your attention.
Thanks a lot. Thank you very much. We cannot thank you enough for this very interesting presentation, these testimonies of your daughter and of patient 2, and also to emphasize the tremendous importance of centers of expertise and of the rare disease initiatives. And yes, you stayed in time. Thanks a lot.